Hi, my name is Corinne Cushing. I'm a third-year medical student at UC Davis School of Medicine, and this is the virtual abstract presentation on my research for the rate of traumatic findings on C-spine MRI following negative CT scans in older patients after a ground-level fall. The principal investigator for this research is Dr. Katren Tyler with the UC Davis Department of Emergency Medicine, and statistics were performed by Dr. James Holmes with the UC Davis Department of Emergency Medicine. All three authors for this research have no financial conflicts of interest and no disclosures. So to give some background on this research, there's currently very limited evidence on the utility of MRI C-spine after a negative CT C-spine in patients over 65 years old after a ground level fall. Because this additional imaging adds cost and time to the patient's stay, and elderly patients may also have to be sedated, it is worth evaluating if this additional imaging is providing any clinical benefit. The objective of this research was not only to examine the incidence of positive MRI C-spine findings after a negative CT C-spine, but also to evaluate if those positive MRI findings were leading to any change in the clinical management of the patient. Our hypothesis was that if there were no acute neurological deficits when the patient presented to the emergency department and the CT C-spine did not show any acute findings, then an MRI C-spine did not find any additional injuries that would require intervention. This research was conducted as a retrospective chart review from a single level 1 trauma center. An ICD-10 search identified patients from May 2017 to May of 2019 with a negative cervical spine CT who also underwent an MRI of the cervical spine. Patients were selected if they were over 65 years of age and presented to the emergency department after a ground level fall. The inclusion criteria for this study were age over 65 years, presenting to the emergency department after a ground level fall, and a negative cervical spine CT. A ground level fall was defined as a fall from standing, a fall of less than 3 feet, or a fall from less than 5 stairs. A negative CT C-spine was defined as no evidence of acute traumatic injury on the radiology report. Interfacility transfers and prisoners were excluded. Study data were collected and managed using REDCap at UC Davis. Demographics, comorbidities, ED examination findings, diagnostic studies, and diagnoses were all abstracted following accepted chart review guidelines. Revised trauma scores, Charleston comorbidity indices, and injury severity scores were calculated. An analysis of the data was done by simple descriptive statistics. You can see the results of the data abstraction here. 341 charts were reviewed, 190 were eliminated because they did not meet the criteria for a ground level fall. 48 were eliminated because they were on interfacility transfer, and 8 were eliminated because there was no initial CT C-spine. This was mostly due to a patient history of metastatic disease. There were 87 initial CT C-spines without acute injuries who had a subsequent MRI. Of those, the MRI showed no acute injuries in 77 patients, and the MRI showed acute injuries in 10 patients. Here are some initial results comparing the group who received an MRI with no subsequent findings and the group who received an MRI with acute injuries. For age, sex, cognitive impairment, Charleston Comorbidity Index, and pre-existing DNR, the groups are very similar. Here are some additional statistics between the two groups. Of note, both midline C-spine tenderness and anticoagulation trend higher in the group with acute findings on MRI C-spine. The injury severity score and revised trauma scores were very similar between the two groups. The trauma team was activated on 100% of the group with additional MRI C-spine findings. Many of these were because the patients were anticoagulated. The rates of admission were similar between the two groups, but the ED length of stay was slightly longer in the group with significant findings on C-spine MRI. To review the results, 64 out of 87 patients presented to the emergency department with no focal neurological findings. 23 patients presented with focal neurological findings, which would be an indication for an MRI even after a normal CT. Of those, 21 had a normal MRI and 2 had an abnormal MRI. Of those, only 1 patient went to the operating room for surgical stabilization. The limitations of this study include that it was a single-center study with a retrospective observational method and a limited sample size. In our single-center study, 11.5% of patients had an acute traumatic injury on C-spine MRI following a negative CT scan. In patients with no neurological deficits at the time of original assessment, none had a positive MRI for acute traumatic injury after the negative CT scan. Further study with a larger sample size is required to identify criteria to determine when MRI should be performed in this population.